Hello everyone, this video is going to be about sexual dysfunction disorders, and we are going to go through, I will tell you, erectile dysfunction, Dysperiunia, altered libido, gender dysphoria. Did you hear that? Let me say it one more time. Erectile dysfunction, altered libido, Dysperiunia, and gender dysphoria. And so that's 4 of them. All right, so we're gonna first talk about Dysperiunia. All right, so I'm gonna explain the causes, the clinical manifestations, and the interventions of this. So the causes of Dysperiunia could be multiple causes. There could be in women, so women are a little bit different than men. So in women, it could be a pelvic inflammatory disease, endometriosis, bladder prolapse, injury related to childbirth, trauma. There's many different reasons why they can have pain during intercourse. There could be physiological changes, like think of menopause, the inhibition of lubrication, skin irritation, infections from think of STIs, maybe they have lesions, you don't know. There could be multiple, so Dysperiunia is just saying an overall arching term is pain during sex or intercourse. All right, there's also medications that can cause dryness, antihistamines, which dry you out, cocaine, amphetamines, menopause. Okay, so this is going to affect sexuality. And I want to review this. Amphetamines increase, that's so interesting. Amphetamines increase sex drive but delay orgasm. Antihistamines decrease vaginal lubrication and decrease desire. So think of your antihistamines, like, isn't that like your, like, think about it, it's antihistamines, like what you take when you need to when you have an allergies, antihistamines, allergies, decreased vaginal lubrication and decreased desire. So that's your antihistamines, and it will dry you out. That's kind of what they do. Okay, so now we're going to keep going on. So those are some of the let me just remember what cocaine. All right, so these are very interesting. I'll have a whole video on about drugs that affect sexual dysfunction. Okay, so basically medications, physiologic changes, pelvic disorder, disorders can all affect in the woman. In the men, they could be infection or inflammation to the testes, urethra, foreskin. The foreskin is also a place that can create infections, and you see that's and the prostate gland. So maybe the prostate is very enlarged. Medical condition from aging, psychosocial. There could be many reasons why a patient would be having Dysperiunia. All right, so clinical manifestations that you're going to see is genital pain before, during, and after intercourse. That's clinical manifestation. It's basically the definition in itself. It's more prevalent in women and originates in the vulvar surfaces and the deep pelvic structures. The pain can be mild to excruciating, described as burning, stinging, sharpness, extreme tenderness. So this is what, like, the descriptions you're going to hear from your patients if they're talking about Dysperiunia. The interventions. Now that's where the nurse comes in and what they're going to do about it. And like when we were like, so what are we going to do about it? Okay, so the nurse so teach them to maintain open dialogue between the spouse and the nurse to further contribute to sexual well-being. So make sure you don't avoid this conversation when you're going into the patient's room. Address lifestyle changes like decreasing alcohol, caffeine. Alcohol can actually, initially, like on moderate amounts, it can increase sexual drive, but when it's prolonged use, can actually create sexual dysfunction, which is interesting. Caffeine, vaginal moisturizer, so decrease alcohol and caffeine. Caffeine increases your parasympathetic system, but when it comes to your vaginal organs or your penis, it will actually decrease the amount of blood flow that can go down there, because that happens while you're on your it happens in your parasympathetic, not your sympathetic, because you're relaxing. All the blood flow is going down. All right, so address lifestyle changes to decrease caffeine, alcohol. Vaginal moisturizer will may be suggested, and exercise and weight reduction, but they always suggest that. just to be healthy for normal care. Some self-care, teach them to they may suggest them to increase foreplay to help with stimulation. Dysperiunia is when they're talking about that discomfort. So plant estrogens, like brown rice, green beans, lemon, tofu. These foods are estrogenic foods and may improve for the vaginal dryness. So just tell them that. Water-soluble gels like Replins, water-soluble lubricants. There's a KY jelly, Astroglide, Replins, and hormone cream. So there's different creams to use to help get that area lubricated. They may need sex therapy for this, and medications there's a vaginal estrogen preparation, so lasofoxifene, ospemifene, and estriadol, which is estrogen. Hold on, lasofoxifene. I want to look that up real quick. Osmofoxifene. I can't find it. Well, it's something that's out there that patients can be using. So it's vaginal estrogen. Oh, that's obvious. Vaginal estrogen preparation. So preparing the vagina. Vaginal testosterone may be given. Oral transdermals. So that's everything that there is out there. So just know that this Dysperiunia is that discomfort while having sex. All right, now let's talk about altered libido. That's a sexual arousal disorder. So basically, not really feeling it. So when a patient says, I'm not really feeling it, I have a headache, all that stuff, yeah, altered libido. So there could be many reasons for this. It could be medications, it could be relationship issues, it could be hormones, it could be psychological, physical, so there's many reasons. So let's talk about some of the medications. Side effects to many medications like alcohol, antihypertensives, antidepressants like Prozac and Paxil are common. So a relationship issue, just honestly, you're not feeling because like psychologically you have a negative relationship maybe. Hormones, hormone deficiencies, menopause would be example, or perimenopause. Your hormones are going down, less estrogen, less progesterone, testosterone. Sexual trauma, negative attitudes towards sex when you were a kid. Maybe your parent had told you sex is bad. Some physical could be advanced age, heart disease, diabetes, trauma. So less blood flow to the area. Okay, so our treatment is very simple. You just wanted to improve communication with your partner. And hormones, you may have to give estrogen or testosterone to increase their you may want to increase their desire. Counseling will help. Use artificial lubrication if it's the vaginal dryness making them not want to have sex. Lifestyle changes. Lifestyle changes can include exercise, stress less, support groups. They may need to cool down. Counseling, we talked about that. And medication, they may need to switch, for example, like Bupropion. So I want to discuss real quickly on this chart that I see sexual side effects to some medications. So there's like cardiovascular drugs, some gastrointestinal drugs, hormones, sedatives, anti-anxiety drugs, antipsychotics, antidepressants, and anti-manic drugs. So anti-manic drugs, lithium lowers in libido. Lithium lowers libido? That sucks. And impotence. And so so basically lithium is associated with low libido, like low desire, and impotence, so infertility. Antidepressants, we can think about our MAOIs, our tricyclics, our SSRIs, and our atypical. So they each cause a little bit of difference, like impotence, retarded ejaculation, anorgasms, low libido. So antidepressants lower libido. Antipsychotics would be like Halprodol, Risperidone. This can decrease libido. Anti-anxiety drugs, diazepam, can lower libido. Sedatives, alcohol, barbiturates. Higher doses cause sexual problems, impotence, so that's not as associated with the low libido. Hormones, estrogen and progesterone are associated with libido in men and low libido impotence. Gastrointestinal is methylamine impotence. Cardiovascular drugs would be your thiazides, propanol, digoxin. So these can lower libido. This does not look like a good list. So basically a lot of drugs can lower libido. So just be monitored that they may need to switch drugs, and that there may be a way just like to have an alternative, because that may be the reason that they have sexual dysfunction. So that's the main takeaway from that. All right, so the next one I want to talk about is erectile dysfunction. So erectile dysfunction, our causes could be 2 categories. So I want to focus on the 2 categories because that's like really, really important to understand, so we can be able to understand how to treat it. All right, so our causes could be sudden. Usually sudden is associated with like psychological, and our gradual is usually associated with like physiological. So our sudden, like our functional, is associated with us, like functional is more like a psychological thing. So it's functional, like I'm feeling stressed, I don't feel like I'm not having that I'm having erectile dysfunction. Well, I mean, I'm not a guy, but you get the point. Organic is like that underlying problem, like it's gradually becoming worse. Maybe I have diabetes, maybe I have this, like the concept of like an actual disease process. I'm becoming older. Okay. So the clinical manifestations you're gonna see is, think about, like, watch what those patients are saying to you as a nurse or a doctor. I can't satisfy my wife, or I don't feel like a male. And what you're going to see is they're going to say, if they're really honest with you, they have an inability to achieve or maintain an erection for sexual intercourse and lasting, and this has to be lasting more than 6 months to be considered classified as erectile dysfunction. So the inability to achieve or maintain erection for sexual intercourse is erectile dysfunction. We talked about the types. So now what assessments are there? There's a digital rectal exam. This can test for the prostate size, consistency, and any nodules there. There's a Doppler, duplex Doppler exam that can test for like blood flow. Hormone testing is what is their testosterone level, because there are many different reasons. Serum glucose levels, lipid levels you're going to want to test. Maybe they have cholesterol problems, maybe they have diabetes. Blood pressure, femoral arteries, peripheral pulses, because really your genitals have a lot to do with your vascular. Because if your vascular is not functioning properly, you may not be getting blood flow. A way to separate between functional and organic underlying problems would be to test a nocturnal penile tumescence, is what it's called, and rigidity test. This test for during the night, if the patient's able to have the evening, if they're able to have an erection. This can differentiate, because if they're able to have it especially in the mornings and nights, this is functional. It means it's associated with being stressed, which would differentiate from being an organic problem, underlying problem like cardiovascular diseases or aging. All right, so now what are the interventions for this is, there's a bunch of things to consider. Is like they may need sex therapy. There is a vacuum constriction device, penile implants. There's a bunch of different fancy things. If they have a penile implant, they'll need counseling needed to adjust to this implant, because they may need to like blow it up, and then they'll lose their autonomy of being able to do it on their own. There's a thing called Intracranosal Injection, and the main thing to know is, like, most common is there's a medication for it. There's a thing called a PDE5 inhibitor. So the thing about this medication is, in order to function, the onset is 30 to 60 minutes, and you can only take it once daily. So basically, you can only have an erection once daily. So yeah, so take it 30 minutes to 60 minutes before you plan on having that erection. Then it's called a PD phosphatase something inhibitor. So the main thing I would say about this, I would say the side effects is a headache, dyspnea, flushing, and nasal congestion. I'm just trying to think. It's contraindicated for patients on nitrates, because I think it's like increasing. So they'll have this headache, this dyspnea, flushing, which nitrates is really associated with flushing too, so that makes sense. And call HCP, healthcare provider, if the patient sees blue or green vision, sudden hearing loss, or erection lasting longer than 4 hours that will not go away. So remember that. So any of the blue green vision that lasts longer than 4 hours that will not go away, then it's time to call the health provider. and 30 minutes before the erection. All right. So then I want to talk about the last one is about gender dysphoria. So the causes of gender dysphoria could be hormone, your genetic factors is Klinefelter syndrome. That's XXY. Well, that's just when you have both organs, so then you don't know what to choose because you're both. But hormone absence of having the same-sex parents can also, to not having that role model figure between that 1 to 3 years age of having gender identity. So that could be the problem. Other things to consider. Okay, so the assessment you're going to see is psychosocial. You want to ask the questions like this: is there challenges or concerns or anxiety related to your sexuality? And you do need to ask the patient these things. Don't avoid it. Physical, be mindful of their organs. Do they have female organ parts even though they want to be addressed as a woman? Be mindful that they may still need a breast exam even if they want to become a male, unless they actually don't have breasts, or vice versa if they decided to get breasts. Be culturally sensitive and non-judgmental. That's really important to be able to not be judgmental and be very culturally sensitive, and use pronouns that match the patient's preferences, but also be mindful if they're dressed a girl, they probably want to be addressed as a woman. Okay, so there are different stages. Okay, so first I want you to know that there is a DSM-5, and for a DSM-5, that different criteria to be considered gender dysphoria, and they have to have a very strong preference to be considered this way, or all the words have a synonymous meaning of strong when you look at the DSM-5. Adults only need to have two of them, and children need to have 6 of the qualifying factors. All right, so the nursing diagnosis would be disturbed personality identity. There are many different diagnoses you can give. It's a psychological disorder. The stages, they could be transsexual, where they actually had the procedure done, preoperative transsexual, intersexed, and cross-gender transvestite. So there's different stages of being gender dysphoria to be aware of. Okay. So now interventions, what are we going to do for these patients? So the main things to take away are be aware that the transgender community may be avoiding healthcare settings. So unemployed, have no health insurance, they may lack respect based on previous experience. So if they had that previous experience, they've been traumatized and they don't think they're going to get that respect. So make sure that you provide the most respect as possible. Monitor for fistula, bleeding, or wound infections. Oh no, I'm talking about surgery. Okay, so if they do choose to have surgery, you have to monitor post-operatively for fistulas, bleeding, and wound infections, which is pretty much like most surgeries. Okay, let's talk about hormone therapy, and let's talk about surgeries. All right, so if we're becoming male to female, they were wanting to be feminized. They're going to need estrogen replacements. Estrogen therapy, there's a choice to block testosterone. There's 2 ways to do this. Estrogen therapy is 0.1 milligrams patches, changed twice weekly. So there's patches, or there's injectables, and they're 5 to 20 milligrams IM every 2 weeks. So basically, you got your patches, you got your injectables, IMs, so it depends on what the patient prefers. There's just those choices out there. For testosterone, 5-alpha reductase inhibitor. This is typically used to treat benign prostate hyperplasia, but it can also, so hyperplasia is when the prostate is becoming too big, so I guess they're trying to shrink it. So this blocking 5-alpha reductase inhibitor can also help reduce and block that testosterone level. So, which is kind of interesting, actually. Because this is when males trying to become a female. All right, so what are the side effects of estrogen? Estrogen is just not pretty. All right, so you can have headache, breast tenderness, nausea and vomiting. weight gain, estrogen, you think of weight gain. Teach the patient to report any anxiety or depression associated when they're on the estrogen. Estrogen is known for fluid retention, like hypertension, watch for that. Estrogen dependent cancer can happen, VTEs, venous thromboembolism, and gallbladder diseases. So watch for that. And so they'll maybe be retaining. So estrogen, which makes sense because I feel like women really do retain fluid. All right, so now let's talk about female to male, so becoming more masculinized. Oral andriol is the least effective, and testosterone is more effective. It's a buccal implantable form. So let's look at the notes. If patient does not stop menses in the first 3 months, then the patient is placed on depot. Given IM to start low and then increased every 1 to 2 weeks, placed on depot every 3 months until effective. Some changes take up to a year. So be mindful of that. So oral andriol is the least effective, depot, testosterone isn't it, and then there's a buccal implantable form. So depot is those injections. So give IM starting at, I just want to see it one more time. IM, start low, and then increase every 1 to 2 weeks. Place a depot every 3 months until effective. All right, so what are the side effects of female to trying to become a male? Edema, acne, oily skin, weight gain. Just think of that guy with all the pimples, honestly. Liver and heart disease, screen before administering, because this is a high risk. Testosterone is high risk for liver and heart disease. Increased LDLs and decreased HDLs. That sucks. So basically, their LDLs are going to increase, their unhealthy ones, and their healthy ones are going to decrease. So this is not good. So increased blood glucose and decrease clotting factors. So they're going to increase blood glucose and decrease clotting factors. Okay. So just know this. So their cholesterol is going up, their glucose is going up. So there may be contraindications for this. All right. So feminizing surgery versus masculinizing surgery, this is considered the only treatment option there is for gender dysphoria. Feminizing treatments, there's a lithotomy position a long time, teach to move legs often the first 24 hours after surgery. So it's a bit challenging to make a woman. So if the patient in the lithotomy surgery, teach them to reposition and also report any numbness. So reposition often in the first 24 hours. An ice pack is placed over the perineum of their new vagina, I guess. Monitor intake and output and bleeding. But this is like post-op care in general. All right, so let me look at the notes real quick. All right, feminizing surgery is male to female. There's a breast and chest surgeries. Augmentations, there's partial penectomy, orchiectomy, facial feminizing surgeries, reduction of the voice, thyroid, chondroplasty, because estrogen can increase a girl's voice, but testosterone can't exact. So when a male is trying to become a female, they're trying to reduce their voice, but testosterone doesn't do that exactly. All right, so masculizing, that's the feminizing surgery. The masculizing surgery, they're going to do this different way. So there's masculizing female to male. They're going to have a mastectomy, which is your breast, hysterectomy, vaginectomy, because they're trying to get rid of all these uterus and vagina and all that. Phalloplasty is very difficult to do, actually. It's kind of like an art if you think about it. So the skin flap from the radial arm back to create the penis is how it's done. Sometimes the women don't do this because they feel like the penis is too small. Fat grafts to increase the length in the urethra is used. Use buccal mucosal tissue as well. So it's kind of hard to make a penis is what we learned in class. Phalloplasty is a common complication. Urinary retention would be common. donor graft sites, scarring can happen. So it can also become dead tissue. Yeah, so monitor for that. All right, so that was everything for sexual dysfunction, and another video will be made to further discuss about all the medications associated with it. All right, so happy studying.